I hope everyone had relaxed holidays. Actually, it has been a good day for child psychiatry today for two reasons. One is we got our match results for the training program. We were able to fill our positions with good candidates. So that's one. The other thing is we have Dr. Robert Clean here. We have been trying to get in touch with each other, and we worked on this and worked on this. Then we met in Toronto. That's where we finalized this talk today.
That's right.
So Dr. Robert Clean, he's going to be talking about recent research on sex offending behavior in youth and adults with developmental disorders. I'm going to do a little introduction, then he's going to expand on that. Dr. Clean, he's a medical director, Division of Developmental Disability, State of Arizona, and he's also on teaching faculty, Maricopa Integrated Health System. I'm going to tell a few more things.
Please, go right ahead.
He did his BA in History and Science at Johns Hopkins University in Baltimore, and then MD at Wayne State University, Detroit, residency in Psychiatry and Child Psychiatry Fellowship at the University of Wisconsin. And he has held a number of academic positions. He was at Northeastern Ohio University College of Medicine, University of Pittsburgh, University of Wisconsin as a clinical assistant professor, has written a number of papers and presented a lot. And one thing is he has been very active in the American Academy of Child and Adolescent Psychiatry. It's really nice to have him there and actively participate. And he got award in 2001 from American Academy of Child Psychiatry, Catch in the Rye Award. He was involved in developing a instrument called CA Locus, which is how you assess patient's level of care. So I really appreciate him coming here. He doesn't have a financial disclosure, but he may have some disclosure he was going to tell you.
That's correct.
All right, thank you.
Thanks very much for that introduction. Just a little word about the CA Locus. It's been reconfigured as the CASI and is actually used by the state of Arizona as well as other states for their managed Medicaid in terms of putting kids in the appropriate level of service intensity. Here's a little information about my current activities. I'm the president of the Greater Phoenix chapter of the Arizona Society of Child and Adolescent Psychiatry. Sounds great, but actually the main role of the president is to line up the CME speakers every month. So it's actually a working job, because if you don't get presenters, then you're up. So also wanted to mention that I am the consulting child psychiatrist at Children's Rehabilitative Services up in Phoenix for the last 11 years. And my clinical interests are, as they're stated here, no financial interests to disclose, no discussion of off-label prescribing today. However, I would characterize this as learner discretion advised. This is for mature audiences only. We are going to be using some colorful language today and discussing sexual deviant behavior. So with that, we'll go ahead and start. Our educational objectives for today are to be able to recognize passive versus active sex offending behaviors, to identify spelling errors, in identify counterfeit deviance in persons with developmental disabilities. We're going to talk more about that in a few minutes, but basically counterfeit deviance is behavior that looks like deviant sexual behavior, but is actually related to many factors that are unique to the developmentally disabled individual. And we're going to talk about that. We're going to, close to the end, we're going to talk some about how to define sex offending behavior in persons with autism. And you're thinking, well, since they don't really interact with other people, how might that kind of behavior occur? Well, by the end of this hour, you'll have at least a start in looking at that. Because we're talking about sometimes uncomfortable information, there's going to be a little humor in the talk. So one thing that I like to say is, where did I go on my summer vacation last year? I went to a week-long program at Brock University. Thorold is about 15 miles from Niagara Falls, and they brought in experts from Europe and North America to present on the behavioral assessment and treatment of sex offenders with intellectual and developmental disabilities. They have an ongoing program. They have 2 week-long seminars every year. If this is an area of interest for you, learning more about the treatment of the developmentally disabled, then this is the place to go. The weather that time of year is perfect. So that's what I did on my summer vacation last year. All right, the conference faculty. Bill Lindsay is a very colorful man, and I think you need kind of a colorful person to kind of bring some humor to this issue, and so I'll be talking a little bit about his approach to this as we go along. For example, he felt very strongly that in order to be really comfortable in talking about sexual deviance issues, you have to be comfortable with the kind of language that people use. He has got a pretty thick Scottish accent, which is, if you're a Star Trek fan, it's a little bit like getting a lecture from Scotty from Star Trek, which was, as a Star Trek fan myself, I was vastly amused even from that basis. But he's got such a thick brogue. So when he used colorful language, it didn't sound offensive because he would say, well, fook this and fook that while he was talking, and it actually sounded cute, so I wasn't offended. So I'll probably use the Scottish term if I need to as we proceed today. And so he had a lot of slides in his presentation that I don't have privy to, but before we end, I'll share one of the slides that he did share with us, just to keep a sense of humor about this particular issue, which is really sensitive. You know, I think the American culture tends to shy away from talking about this. I think even normal sexual behavior, though I love my parents very much, and my father's a physician and a retired physician, and my mother is a retired nurse, they didn't do a really good job with sex education. They did give me a pamphlet which showed male sexual organs and female sexual organs, but they removed those pages that really talked about how those organs got together. And that's kind of how, I think, a nice example of how we kind of treat that. We certainly don't want to think that people with IQs below 70 have any interest in having sex or getting married or having girl or boyfriends, or even there's no reason that a person with developmental disability can't, their sexual preference can't be homosexual. In fact, that's something that we have to work with our providers and folks up in Phoenix, is that no, this is how they are normally, this is their sexual preference from a very early age, no different than for persons of typical development and intelligence. And so Still, I think there's a reticence to kind of look at deviant sexual behavior in the general population, but equally so, if not more, for persons with developmental disabilities. Dorothy Griffith also did a lot of the presentation on counterfeit deviance. She's on the faculty at Brock University, and Mark Goldman talked about autism, and he's in private practice, I think, somewhere on the East Coast. So, with that as an introduction, we're going to talk about passive versus active offending behavior. Passive offending behavior is basically taking advantage of an opportunity that presents itself. A good example of this is someone who's taking their evening walk down the street. They see an open window and they look in it to look at a person, man or woman, depending on their sexual preference and their own particular sex. That they peep in a window that's open that they did not seek out. Coming back the next day, however, is an active offense, because now you know the situation, you're taking purposeful steps in order to achieve that same level of sexual gratification. Other active offending behaviors include the grooming of victims and creation of situations where offending behavior may occur. Going back to that same, looking for that same open window, going to a park where your preferred type of victim will be found. That's active offending behavior. In the typically developed population, there is a predominance of active offending behaviors. And so the question was, and a lot of researchers, including Professor Lindsay, had the hypothesis that because of their intellectual deficits, passive offending behavior was going to be more common in sex offenders with developmental disabilities. And when they did the research, that was untrue. Active offending was more common, actually, than passive, similar to what's seen in the normal range. The difference is that due to the intellectual limitations, the complexity of the grooming behaviors, the complexity of the planning wasn't to the same extent as you might see in a sex offender of average intelligence. And so one of the preconceptions that many people have is you can only treat sex offenders in locked residential facilities. Well, there's not room for that. And the elements of providing community-based treatment for sex offenders can be provided. There are a lot of barriers to getting persons with developmental disabilities the appropriate treatment for sex offending behavior. One is recognition that this is actually something that may happen in a relatively small number of persons with developmental disabilities, but then saying, well, we can't provide any treatment for those folks because they wouldn't respond. We have often had the same arguments and discussions with folks about providing psychotherapy services, cognitive behavioral interventions for persons with developmental disabilities, whereas the literature is pretty clear that those things do work well. And Dr. Lindsay has a great deal of information, his own research looking at these particular issues. And the core features of the treatment that he provides to his folks in Scotland is individual treatment. And one of the things he really focuses on is continual reinforcement of motivation for treatment. What And one of the important things there is developing that sort of group awareness, giving people the sense that they have a place in the community, that they have connections in the community they can lose if they reoffend. And I think that's a very important part of his philosophy of treatment. Psychiatric evaluation and management is very important. Any comorbid disorders need to be treated. Group-based intervention targeting social skill development and reduction of offense-related thinking. We're going to talk about a little bit more about that in a few minutes. Drug and alcohol awareness, actually drug and alcohol treatment. Not surprisingly, the use of alcohol and drugs increases the likelihood of reoffending, both in the population of folks with average IQ, but definitely in the population of folks with IQs under 70. And so whatever internal constraints are put in place through therapy and treatment can be taken down pretty quickly with a night of drinking. So they really look carefully at those issues. As I mentioned just a minute ago, Bill Lindsay talks about give the offender something to lose by reoffending. This is another very important piece here. Coordinated treatment of anger-related issues is almost always required. Remember, regardless of what your IQ is, the average person engaging in violent sexual behavior, it's about power and control and not meeting sexual needs. However, some of the more there is a place in terms of related to fetishes and that sort of thing, where it's not anger related. But this has got to be a very important part of the assessment, and definitely helping folks manage anger related issues, and looking at the psychopharmacologic management of anger is certainly a piece of this. Strong linkages between treatment programs and criminal justice. Dr. Lindsay was very clear in saying that's just not by intergovernmental agreement, but by personal relationships. Because when things don't go according to plan, which that's life and things don't always do that you need to fall back on those personal relationships to keep programs going and keep the referrals coming in. Another thing that is taken sort of for granted is the great majority of persons who engage in sexually abusive behavior were sexually abused themselves as children. And again, this is a significant minority, but it's not the majority. Dr. Lindsay's sample of several hundred individuals that there was a greater incidence of sexual abuse among sex offenders, 32%, versus non-sex offenders with developmental disability at 17%. So it's not the explanation for the majority of individuals. So what he did was look at over about 20 years as to recidivism rates over a 20-year period, and he kept a running tab of how successful, his program was. And so what he did is over 20 years, every year he added persons to the cohort. So he had some of the cohort had started treatment 20 years ago and remained in some connection with his program, and others had 1 year. So it was a cumulative review. And in the 2 years prior to treatment, there were 300 sex offenses and 600 other criminal offenses, often, again, related to assault due to those anger management issues. Now, when looking at the treatment cohort following completion of their treatment and followed for up to 20 years, there were only 60 new sex offenses and approximately 200 other criminal offenses. So a pretty big drop in sex offending behavior with this community-based approach. So let's talk a little bit about the risks of reoffending here. And we'll talk a little bit about significance here. I want to really focus on a couple of things. Look down at the lower right-hand corner. One of the things most highly correlated with reoffending is allowances made by staff. Meaning, oh, that poor guy, we'll let him off the hook this time. Not a very good treatment strategy. Because remember, there's a little bit of sociopath in all violent sex offenders, and they just see that as a sign of weakness and take an inch, and then they take another inch, and that sort of thing. And so it's highly correlated with reoffending behavior. Poor compliance with management and treatment routine, also very highly correlated. Poor response to treatment. To me, that's a measure of both factors within the individual, but also within, a particular treatment provider where there's not a good match, if you will, with the person in treatment, so that there's not the type of relationship that's needed. But I think the most important thing in terms of treatment is not feeling sorry for the offender and letting them off the hook. So here's a little more information about allowances made by staff, not consistently checking up on an individual to ensure treatment compliance. Well, Charlie, did you go to group today? Yeah, sure. And not checking with the therapist to make sure that he actually made it to his group. And not communicating with other members of the treatment team about individuals' behavior so that trends can be identified. So if Bill is sort of starting to hang around near public bathrooms, or starting to look in doors that are cracked open, and nobody's comparing notes, then again, you can't intervene to change the intervention and discourage the behavior. So let's talk a little bit about counterfeit deviance. That's defined as behavior that appears deviant, but upon investigation is the result of other unidentified factors. Again, I referred to deficits in the typically developed population, if you accept the hypothesis that I'm a typically developed adult. That's humor there, but never mind. So if it's poor for us typically developed folks, it's going to be even more problematic for individuals with developmental disabilities who very seldom get adequate information on appropriate sexual behavior, understanding their own anatomy, those sorts of things. And so in a situation where appropriate sexual knowledge and appropriate sexual relationships aren't supported, then any expression of one's sexuality can appear inappropriate. So I think one of the issues is to ensure opportunities for appropriate socialization and relationship development. Up in Phoenix, there are at least a couple dances for folks with developmental disabilities, well-structured and chaperoned, to help folks have appropriate ways for socialization. So let's talk about some hypotheses for counterfeit deviance. If a residential, meaning where they live in the community program, doesn't allow for privacy, then any sexual behavior is going to be public. So what's the appropriate solution? Isn't labeling a person as a sexual deviant, but it's to work within the system to gain privacy rights for that individual. Another hypothesis is that modeling behavior. So if staff in group homes, and all of these examples occur in practically every. I talked with folks at the training in Canada from the U.S., Israel, and a few other countries, and the same issues are present everywhere. If the staff in the facility are engaging in inappropriate behavior, up to and including sexual behavior while they're working, or dress inappropriately, they're modeling behavior that the persons living in the home are going to try to engage in themselves. Now, is it appropriate to label those folks as sexual deviants if they're trying to engage in behavior that's been modeled for them? No, the appropriate intervention is teaching the staff to behave better while they're at work. Behavioral hypothesis. This is a true story from one of Dr. Griffith's programs, that there was an individual who just before chore time would begin masturbating in the common room. Staff would redirect him to the bedroom and chores would be done without him. Is this sexual behavior? No, this is engaging in behavior that the individual knows will get him sent to his room so he can get out of sweeping and cleaning the tables or helping with the dishes. So the appropriate solution is to say, well, if you want to go to your room and masturbate, come on back, but we're going to save the dishes for you until you come back. And lo and behold, the public masturbation went away because the correct reason for the behavior was identified. And again, looks like sexual deviant behavior. No, it's just a way to get out of working. Partner selection. Again, this is close to the modeling issue. Client falls in love with staff and says he won't date girls with handicap. If there aren't appropriate avenues for interaction, like dances, then the only persons of the opposite sex that individual will meet work in the group home. So who are they going to want to date? Inappropriate courtship. The culture of an institute, for an example, culture of an institution before this particular gentleman was placed in a community setting, the culture there, the sexual culture of the institution is that the male clients would show each other their penises in the washroom as foreplay for sexual activity. When the person was moved to a community setting, he was arrested for engaging in behavior that was tolerated and was his sexual outlet in the facility. So again, providing appropriate social skill training, appropriate opportunities for socialization, and meeting appropriate partners for sexual behavior in ways that are acceptable in the community is the appropriate solution, not labeling someone as a deviant who should be arrested and sent to jail. Not that in our state any of that would happen. One of the issues here in Arizona is that almost 100% persons with IQs under 70 are judged to be incompetent to go to trial and be adjudicated. This allows some people with IQs between 60 and 70 who are very well aware of the situation to say things like, and this is a true case from elsewhere in Arizona, an individual who had an argument with his roommate and with premeditation stabbed him. And when the police arrived, he said, "You can't arrest me, I'm mentally retarded," which turned out to be true. However, if you can form that thought and form intent, it's my feeling that those folks actually should be adjudicated. He had the mental ability to know the law let him get away with what he did. And therefore, because he could do that, in my mind, that made him competent to stand trial. Now, not everybody agrees with me, but I think an individualized approach is certainly necessary. Again, lack of sexual knowledge and appropriate behavior and of appropriate sexual behavior can result in something that looks like sexual deviance, but is just related to not knowing when and where the appropriate situation is. Perpetual arousal. Some gentlemen especially either have issues around anxiety or fear around ejaculation and stop before climax, or really don't understand the whole process. And in some situations, the appropriate response is, again, sex education, but also giving the gentleman some support for appropriate masturbation. Whether in terms of, well, no, that's something you need to do in privacy and you really need to clean up after yourself, or just basic sex education with regard to those issues. There are medical issues. This is an example that was brought forward of a female client who all of a sudden jumped up, screamed, pulled down her pants, and started scratching at her genitals on a bus. She was arrested for deviant sexual behavior and taken to jail, where the jail physician found out that she had a really severe yeast problem and had a lot of itching and discharge. The issue was medical treatment for her yeast infection and how to report her symptoms in the future. So if the yeast infection recurred, that she could seek treatment earlier, and also advise her on the fact that it's really not appropriate to drop your pants and underwear on a bus to itch yourself, which again, nobody had provided this individual with. So again, you really have to sort through all of these issues to ensure that you have true deviancy. Another example is learning history. A client as a child had learned to, whenever they made a mistake, to anticipate punishment, they always had to drop their pants and bend over for spanking with a paddle. And so he moved as a young adult into a group home, and when he did something wrong, he automatically dropped his pants and bent over, anticipating that he was going to get paddled for, I think it was in this case, breaking a dish. Counseling was provided, reassurance that if you make a mistake as an adult living in a group facility, well, you need to clean up the dish, but nobody's going to paddle your behind, and you certainly don't need to drop your pants and bend over. And so, again, helping them to understand that as an adult living away from home, things kind of happen differently in interactions between adults. And so again, it becomes a matter of education. The important, another one is medication. Many of the SSRIs will cause either delayed or absent ejaculation or even erection in persons without adequate sexual knowledge. They'll keep trying to masturbate to the point where they injure themselves. And so it's very important to look carefully at medication side effects to see if they're precipitating the behavior. I wanted to share one example that seemed very deviant when it occurred, and that was of an individual who began to use his own feces as in his masturbation. And people were very concerned what was going on here. Not surprisingly, feces got everywhere. It created a very messy and unhygienic situation in his group living facility. And they were all prepared to get complex psychosexual evaluation. But before they did all that, again, it boiled down to an issue of taking a careful look at his sexual behavior in the moment. This was a gentleman who masturbated fairly regularly and was causing some abrasion to his genitals. And he discovered quite by accident one day that he didn't tear up his genitals so much if he used feces, if you will, as a lubricant. And his sexual deviance was cured when the treatment team introduced him to the benefits of KY jelly. And that cured the need to use feces for lubricant and normalized the situation, where again it wasn't a matter of extreme sexual deviance, but a lack of knowledge about appropriate lubrication during masturbation. So to go on to talking a little bit about internal variables influencing inappropriate sexual behavior. Social deficits. I think it's really important to break things down and look at it carefully for our population. A lack of social competence. Again, many of our folks never have much opportunity to carry on normal conversations, let alone with a member of the opposite sex or same sex who may be you may wish to have as a sexual partner. Peer influence. Peer influence plus alcohol results in inappropriate sexual behavior pretty frequently. And just a basic lack of knowledge about appropriate behavior. I love the term the ladder of love, the steps in developing a romantic relationship. What is that ladder of love? How do you let people know that you like them and want to have sex with them? Do you walk right up to them and kiss them on the lips? No, that looks like deviant sexual behavior. And so when you're discussing the ladder of love with folks, you really have to talk about, okay, well, how do you get to know somebody? Well, you get to know somebody by talking to them. And what do you ask them about? The things that they like. And then you talk about what you like and what's the next step after that. So you build the ladder of love, and most of those of us who are typically developed know that there are many stages in the ladder of love and in development that we learn through our high school, college, medical school, residency experiences, so that as competent adults we can climb that ladder of love with success, at least in a few occasions in our adult life. However, if you're not allowed to have those experiences because, well, those mentally retarded people really don't need any of that stuff and aren't given that exposure, you don't know how to approach somebody in an appropriate way and begin those steps towards a relationship. So I think that one of the take-home messages here is that persons with developmental disabilities don't often get opportunities to learn that ladder of love and to really learn how to develop appropriate relationships. Cognitive deficits can result in poor problem-solving skills, poor judgment, memory impairment, so that if they engage in a behavior that doesn't work for them and leads them to trouble, if they have memory impairment, they're going to repeat the behavior because they can't hang on to the fact that it didn't really work very well for them in the past. Not surprisingly, comorbid bipolar disorder increase the risk for sex offending behavior when persons in their manic episode. Schizophrenia actually decreases the risk for sex offending behavior. Some external variables are learning conditions, victimization, segregation. In that, again, in a situation where men and women don't have the opportunity to learn that ladder of love, they're going to engage in what appears to be inappropriate behavior in order to try and meet their needs for companionship and a sexual relationship. Factors including the underestimation of risk, the need to shelter the offender. He didn't mean to do it. He's disabled. Sorry, folks. In most, if not all cases, whether you're developmentally disabled or not, you did mean to do it. And so the consequences need to be there. Data indicating a lack of sex offending behavior while in a controlled setting. Well, he was on an inpatient unit for 3 months and he didn't engage in any inappropriate sexual behavior. Well, that's because somebody had their eyes on him 24/7 and there weren't those opportunities. And so that kind of thinking really results in underestimation of risk. Overestimation of risk. The false belief in all individuals with an intellectual disability are dangerous. It is certainly reinforced all the time on television that persons with developmental disabilities, if they're ever on a TV show, I actually had to turn off Criminal Minds and quit watching it because, you know, they had a very stereotypical representation of a person with intellectual disability and their sexual behavior, and I found it quite distasteful and against everything that I had learned. So the stereotypes are out there. And I want to emphasize the last bullet point here. Another factor influencing overestimation of risk, the degree to which the estimator of risk is being held accountable. You're going to overestimate if there are consequences for you as an estimator of risk if you miss one. And so they'll aim high rather than trying to set the bar where it appropriately should be. Other factors that are involved, the inexperience of the individual, the failure to consider the context of the offense. Each one of the situations that I've already talked about, if you look at them in their context, that's how you determine that it's not sexually deviant behavior. If you look at it in isolation, like the gentleman with the feces as lubricant, that looks quite deviant. You place it in the context, you look at his level of sexual understanding and sex education, and it's not deviant, it's just a lack of information. I also want to emphasize the presence of destabilizers. Loneliness is often a factor contributing to inappropriate sexual behavior. Again, drugs and alcohol. People like to assume that folks with developmental disabilities don't drink alcohol or do drugs when they have the opportunity. They do. And it can certainly impair their judgment just as it does for those of us with typical development. Again, when you're looking at a dynamic risk assessment, as we're getting short on time, I'm going to move pretty quickly through this. A lot of this is pretty straightforward. Dynamic variables are those that can change over time. Again, I want to emphasize anger and hostility versus emotional control. Where they are in terms of responsibility for their own behaviors. Do they have an innate sense of consideration for others? Again, the antisocial personality, one of the hallmarks for them is pretty much an absence of that. And basically, there are few, if any, of the DSM-4 diagnoses that can't be found in the developmentally disabled population. Last thing I want to emphasize from this slide is one of the factors that appears to be related to an increase in aberrant behavior is a decrease in self-care, personal hygiene, or domestic activity. Now we're going to talk a little bit, just before we conclude here, about special considerations for individuals with autism spectrum disorders. Factors related to the diagnosis that come into play here is a lack of social or emotional reciprocity, social skill deficits, repetitive patterns of behavior, and an inflexible approach to problem-solving skills, lacking the social skills to engage in experimentation, behavior with peers, few self-soothing strategies, and their behavior is likely to appear to be exploitative because of their egocentric perspective. Again, in autism, there's a real lack of that ability to take the perspective of others that is different in kind and quality to that of an antisocial person. And so so you're probably wondering, okay, how does a person with autism who really doesn't engage with other people engage in sexually deviant behavior? Mark Goldman related an example of a case that he consulted on for an individual with autism who had a foot fetish. And this came to light when they found hundreds of pictures of torn from magazines of bare feet or people in flip-flops in his closet, in addition with several hundred pairs of sandals and flip-flops in his closet. When they did an assessment of his sexual behavior, what they did is they put about 8 pictures in front of him. Naked men, naked boys, naked women, and naked teenage girls, bare male feet, adult male feet, naked adolescent male feet, naked female feet, adult female feet, and naked adolescent female feet. Not surprisingly, he had no interest whatsoever in any of the naked adults or teenagers. He had no sexual interest whatsoever in any of the naked bodies. His particular focus, he actually asked if he could keep the pictures, would be of adult female and adolescent female feet, which were his focus. And so how he would engage, we're just going to pretend that the podium is another person who's wearing flip-flops. And so this individual would sidle up next to them, right next to them, look down at their feet, and begin masturbating. So again, in keeping with the autism, there's not really an interaction with the victim in that there was no consent obtained prior to the close physical contact and masturbating in close proximity to those folks. But there was focus on that particular stimulus to the exclusion of all others. And so this example for me is very good in sort of capturing the essentials of autism. So there's not really any interaction with the victim. There's this intense focus on the one particular stimulating piece of that. This turned out to be very hard to treat. They had to all the staff in the group home where he lived couldn't wear flip-flops. This wasn't in Arizona where that would be a big problem. But they had to wear closed-toed shoes, wear socks, so that he wasn't constantly overstimulated by his naked sexual objects. He also had to be watched very carefully so that he wouldn't shoplift his flip-flops. What he did, I think, in the long run is they allowed him to keep a few pictures from magazines as objects. They found that trying to eliminate those completely wasn't successful. But again, helped him focus on what's the appropriate way of getting these pictures, not taking somebody's magazine and ripping it apart, but saying, may I take this picture out of your magazine because I like this picture of this lady's feet. And so all of that took a lot of time to put together, but in the long run, they really cut down quite a bit on his stealing of flip-flops and eliminated completely his engaging in masturbatory behavior next to other folks. They were again able to shape the behavior so that it only occurred in privacy in his room at the group home. So again, being able to put all the pieces of the puzzle together and not try to extinguish the behavior. Even persons with autism need sexual release, but shaping in a way that is not offensive to the others, that does not result in criminal or inappropriate behavior, but yet allows him to satisfy his needs. And I think I'm down to my last slide, and I wanted to share with you a quote from Robin Williams that Dr. Lindsay ended his presentation on more than one occasion with. Robin Williams said in one of his comedy sketches, "See, the problem is that God gave man a brain and a penis and only enough blood to run one at a time." And so that was something that one of the good things about comedy is it takes something out of everyday life and puts a human and humorous spin on it. And Dr. Lindsay was very good at that. And with one last salute to Dr. Lindsay, I'll thank you for your attention today and entertain any questions. See. Any questions? So I've answered all your questions about deviant sexual behavior. Yes?
I will ask you a question.
Thank you.
The thing is, you talked about
No, some of the behavior may be not deviant, but because assessment or study with our training.
I think those are very good questions. Basically, what parts of this should be in the average assessment, and are there ways, standardized ways of doing that? And the answer is yes and yes. Basically, I think part of any good complete evaluation of an adolescent, regardless of whether they have developmental disabilities or not, really needs to take a picture of their social development, their opportunities for socialization, their comfort with their sexual identity, and their level of comfort with emotional expressiveness. Have they been in a relationship? Do they know about the ladder of love? How do you kind of do that? And you can approach that in kind of a gentle way, but I think that's an important part of any assessment, is kind of looking at that. And one of the big preventatives, I think, for situations of counterfeit deviance is most of them, the treatment was good sex education. Now, those who know me well know I keep myself busy enough that I'm running from place to place, and I'm always getting to meetings a little bit late. When I went to this training, I was still on call, and so I would sometimes have to answer phone calls before going into the lecture. It turned out to be a really good thing to get there late and have to sit up front, because there was a seat at a table with folks from Israel who did actually they work with all the adolescents and adults with deviant sexual behavior in Israel. And one thing that my friend Ronit noticed is there aren't really any good materials for assessing that, or if they are, that they're kind of stick figures, don't really assess real life. And so what she's developed, and I haven't been able to get my hands on these cards that she has developed, but she had an artist put together, I think it was at least 20 cards to help with the assessment. For example, there's a picture of a little boy standing by a toilet and peeing. And you can ask them, well, is this okay behavior? Well, sure, absolutely. That's where boys are supposed to, and girls are supposed to go to the bathroom. Then there's the next card, shows the same little boy peeing on the playground. And now, is this okay behavior? Should he be peeing on the ground right next to the swing set? Is that okay? And again, having these visual stimuli to ask the questions, and they can go, oh no, you're not supposed to do that, and assessing that the knowledge of where are appropriate places to go to the bathroom is intact. But then it goes through different sexual situations where it's appropriate and not appropriate to masturbate or engage in sexual relations. And again, it allows a nice, straightforward way of saying, well, is this okay? And the people who are, don't really have much education, or they're not had much experience, won't really have that information. And their affect and their looks of confusion and their hesitancy in answering the questions, people will try and cover. Even if they're developmentally disabled, there's this realization, well, people are supposed to know about this stuff, but I don't really know, so they'll try and pretend. But if you're a good observer of people, you're going to be able to know when people are kind of guessing. And so this is one of the better ways of doing that kind of assessment, because they're nice color pictures and don't really look too clinical, which makes them an easier tool. Any other questions? Yes?
Okay, so it sounds like you have passive behavior, you have active behavior,
Yep.
you have counterfeit behavior.
Right.
So, let's see, how do you describe it? So if you have passive behavior, if you have individuals who are low functioning, they're doing this opportunistically, and they may not be able to make a decision about what they do. Then there's may or may not. I don't know.
The evidence is pretty clear, is that both in typically developed and intellectually disabled population, that there is a minority of folks who just engage in inappropriate sexual behavior when the situation arises. However, I'm trying to get at what I kind of sensed in that is that that was even my attitude before this conference is, well, how much planning can folks with intellectual disability do? And actually, you know, it's not elaborate and complex, but they can do some active planning to make sure that the situation occurs again. And so, again, the data shows that at least 2/3 of that kind of predatory behavior is active with grooming and those other things.